Hello, welcome back to House and Human Services on Friday, April 10th. Our afternoon session, a committee meeting. We are taking up H574, an act relating to the use and maintenance of epinephrine at childcare facilities. And we have Janet McLaughlin, the Deputy Commissioner, Child Development Division at the Department for Children and Families, who's going to testify. And we have another witness, hopefully will be joining after Janet. So Janet, you have the floor. Thank you for being here.
Thank you for having me. Nice to see you all again. For the record, Janet McLaughlin, Deputy Commissioner in the Department for Children and Families that oversees the Child Development Division, which is Children's Integrated Services, all things childcare, and Universal Pre-Kindergarten. And relative to this bill, I did have the chance to huddle with our colleagues from the Vermont Department of Health on Wednesday afternoon to review the bill. And, first off, clearly, we are supportive of the goal of making sure that children who need epinephrine can have epinephrine when they need it. We understand that this is a potentially life-saving discussion. We understand that younger children, have had less time to be exposed to different things, and so they may be more likely to have an unexpected reaction to an allergen. So we agree that this is really important. We are requesting additional time to be able to review the sort of medical, practical, regulatory implications of this approach and to potentially propose a different approach, but we haven't had the time to do that at this point. This is one of those things that I think feels kind of like a common sense solution, and then my job is to come in and be here's why it's more complicated than you think. But I've got a list of the reasons why, and it's not from not understanding the value that this could have for children and families. I mean, and knowing that this is a low incidence, but usually can be a very high acuity, high serious events with really high seriousness. So offering these just as things that need to be thought about in developing a plan here, not necessarily as not attempting to just put up roadblocks for roadblocks' sake, but to say we've got to identify work through these things. So, and again, I would offer, as you be clear, that my expertise is as a public administrator. I am not I'm not a doctor, I'm not a nurse. And so, the questions, there are certainly medical questions here that I am not the best witness for, but I can convey in talking with my with our colleagues at the Vermont Department of Health. They did want us, they were just thinking through what would be the guidance around dosage, if we're talking about children between the ages of 6 weeks and 13 years, how would we handle that in this kind of a setting? Thinking about staff training, there is essentially this language does apply to public schools, but schools are also required to have nurses on staff. And so there is a nurse on staff to make that decision about delivering epinephrine to somebody who doesn't have a prescription. There's a nurse on staff to store the medication. So that's just from a practical perspective. I'm not saying there's not a way through it. It's just it's not listed here what that way through it is here. My understanding is that in the schools, there has been the schools that have been implementing it, there's the question of the prescription itself, who's holding the prescription? Is it the school that has the prescription? Is it the nurse, that is able to get the prescription on behalf of the school? There's just these real practical concerns tied to it. And again, when you try to apply that to a childcare programs, it's, just a very, there's not a nurse on staff. And so it's not clear who's going to play that role. We do require that every childcare program have somebody who is trained in, folks who are trained in medication administration, and only folks that are sort of trained in medication administration are supposed to be the ones giving the students their variety of medications that they could have. So we'd have to look at what that mean for what's required there and what the training protocol would be there. We recognize that this is not that, it's doable. It just takes some thought to figure out. This is not, is what I felt like I was hearing from my colleagues at Family and Child Health. The other piece is the cost, right? Is who's going to pay for the stock of epinephrine that is supposed to be on hand for childcare programs. And that apparently is something that they've run into at schools as well, is just the practicality of like getting the medication, storing it expires, getting new medication, like all of those details. Apparently there are some programs where like pharmaceutical manufacturers might provide epinephrine to schools at a reduced cost. I don't think childcare programs are considered in that. So there's all of those pieces of it, and then sort of those medical and some of those practical considerations. And then from a childcare perspective, we also are looking at, what would this mean for our, what would be the updates that we would need to be making to our childcare licensing regulations to allow for students to have medication that was not necessarily, that wasn't prescribed, that was a prescription medication, but that wasn't prescribed to them. So we need more time to be able to assess this bill to figure out what could be a way forward. Let's see. Oh, I also wanted to flag, I wonder if maybe there's an idea for another way through this. My understanding is there's some states that have created like community epinephrine programs. So that might be something that's interesting as well. So that maybe like a library could get it, or somebody else, like it's like would be a different way that's like not necessarily childcare specific, but could that potentially address some of the, like be a broader way to address the concerns related to prescription costs, ordering. So those are a few of the thoughts from our team, but mostly it's really just, we would need more time to be able to sort of, assess how this could get done.
Thank you, Janet. Are there any questions for Janet?
No, I don't think so.
A question, when you say, Janet, time, like, how much time would the administration, like, is this something that, I obviously know licensing reg updates are very time consuming and public process, but as far as just kind of figuring out some of the challenges that you listed, like what is the capacity or?
Let's see. I think it would take some time. Like, I don't know that it can be done by the end of May, which I think is your timeline for this year. And because there really are a lot of practical considerations, like I said, especially around the training, the storage, the prescriptions, that those pieces where if we pass this, but then don't actually have a practical plan, then it doesn't actually achieve what we'd like. So, I mean, ideally, we would be able to have through the, we'd be able to give really thoughtful recommendation, like next session, not session, but next. Oh, yeah. We'd have several months at least.
I understand what you're saying, yeah. One more question, Janet. Any other states doing this already that you know of?
Not that I know of.
Okay.
Like I said, we know that the schools do, it is here in this, it is law in
Right.
Vermont for schools to have it. And like I said, we did hear about some other schools. I mean, some other states that are like have a community access. It's more like thinking about it like Narcan or something like that, right? Where it's just like, this is a thing we want to have be available in emergencies. And that had been one of my questions for Department of Health is that the path that like society sees for something like epinephrine? But again, we still have these issues of like, these are small children. And so small children, and there's not necessarily a trained medical professional like on hand. And so we really want to be thoughtful in coming up with a plan.
And Janet, can you send us your testimony? I know this is kind of last minute. I appreciate you being able
Yes,
to.
it will be very
available.
short. It's just written on a notebook right now, but I will put it in.
Thank you. Do you
Okay.
have any questions for Janet?
Hi, Janet. I'm sorry I was delayed. Did you tell her what's going to happen with this bill?
No.
Okay. So we are not going to take a formal vote on, we're not voting this out of committee. But I am going to be transferring this to the Education Committee. They've requested it to review for potential consideration in the miscellaneous education bill.
Mhm.
So just so you can keep track of, what's happening in the places that it's going. And there's a particular representative that is, well, the sponsor of the bill, who is very interested in having it appear in the miscellaneous ed bill. We did not have time to take testimony, full testimony on this year, but I wanted to at least take a little bit of testimony so that if it does end up in the miscellaneous ed bill, we can at least make some recommendations or, give them an idea of what, maybe some of the things that need to be considered. Prior to just kind of, I doubt that they would just kind of like flop it into the miscellaneous ed bill. So it wouldn't surprise me to hear that you would be invited to testimony in House Ed about it if the chair and the rest of the committee decides to put it in the miscellaneous ed bill. I'm sure you'll be asked to testify.
Yeah. Okay. I just thought of a couple other things I could offer in case that's helpful. Okay. So one is we did check with our licensing team, because we have to get incident reports whenever they're from programs, whenever they're, a child needs medical attention, essentially, as a result of being in their care. And, and the team reviews those together. And there certainly are incidences sometimes when kids have had to go to the hospital because of an allergic reaction. But I know that this is like a very like rare circumstance where it becomes like absolutely serious and you have nothing. But I just wanted you to know, like, we didn't, it's not, we don't have a specific instance of this happening in Vermont in which we could like really point to that has been reported to childcare licensing in the recently history. And then secondly, I would say there have been, and people have asked us like, what should I do if something like this is happening in there? And our advice right now is to call 911. And if you're, the 911 operator might tell you, if you've got a different EpiPen, use that on the kit. The other, use it on, like, you should use that. But that's not in childcare licensing. We've kind of, right, ours is really focused on what are the, children should get the medication that they're prescribed to have. So anyway, that's so you guys know, that's just a little bit more context for the current state.
Thank you. We have one more question.
She kind of answered it in what she's saying.
Okay.
Okay.
Any other questions? Thank you so much, Janet. Thanks for being available last minute. Really appreciate
Thanks,
it.
guys.
Okay, next we have Thomas. You with us? Hello.
Yes. Hi, how are you guys?
I'm well, thank you. We're good. Should we do introductions?
Sure.
Yeah.
Sounds good.
Welcome to House Human Services. We appreciate you being here. We're going to do a quick round of introductions and then you can have the floor and provide your testimony. I am Representative Ray Garofano. I represent Essex and Essex Junction. Yeah.
Okay, I'm Jubilee McGarren, and I represent Bridport, Middlebury, New Haven, Weybridge.
Hi Thomas, I'm Rep. Esme Cole and I represent Hartford.
Hello, I'm Doug Bishop and I represent Colchester.
Hi, good afternoon. Eric McGuire, I represent Rutland City.
Good afternoon, I'm Dan Noyes. I represent Wolcott, Hyde Park, Johnson, and Belvedere.
Good afternoon, Thomas. My name is Teresa Wood and I represent Waterbury, Bolton, Buell, and Huntington.
We'll go to the screen first.
Oh, screen, yes, we have
Yeah.
Representative Steady.
Hello, I'm Brenda, Representative Steady. I do East Milton, Westford.
Great.
It's a,
And we have a couple of more people in the room.
Hi, my name is Brian. I'm an intern for Representative Noyes.
Get over here, I'm Lori. I've been emailing you.
Particularly people who are new to the committee and especially on Zoom, I think it's helpful because it's hard to see with the camera who exactly you're speaking with. We like people to be able to know who all is in the room. So we really appreciate you being here. And I understand you're gonna, share, your personal story around this issue. And thank you so much for your willingness to do that.
Yeah, no, absolutely. Just thank you for having me and hearing this testimony. And I would love to give this pretty much will clear a lot of the context that you're having, questionings that you guys are looking for. So if I may, I would love to read my testimonial letter, if that's okay.
Yes.
please.
So, thank you guys. Thank you, honorable members of the committee. My name is Thomas Rivera. I'm the co-founder and vice president of the Elijah Alavi Foundation. And I write in strong support of H574, an act relating to use of maintenance of epinephrine in childcare facilities. And give you a little premise is our foundation was created in memory of my son Elijah, who tragically passed away after being exposed to a known allergen in his childcare setting in New York City. So his death was definitely preventable. And since then, me and his mother have dedicated our lives to ensuring that no family experience such a loss again. And we've been doing a lot of work across the country, passing laws in his name that protect the most vulnerable, especially children. So through our advocacy, Elijah's Law has been enacted in multiple states. We're talking about 6 states and also 2 other states that have city ordinance, which we strengthen the food allergy policies, the training, and emergency preparedness in childcare environment. Yet there's still critical gaps remaining across the country, and many children, particularly those between the ages of 0 and 4, experience their first allergic reaction in childcare settings, often without prior diagnosis, unknown to the educator or even to the parents. So this means that the reactions can occur unexpectedly without a prescribed epinephrine device on hand and leaving staff unprepared in life-threatening moments. So having such legislation as H574 addresses the urgent need by allowing childcare providers to maintain undesignated stock supply of epinephrine and training designated to personnel to administer it in the event of emergency. So I know that this is not just a policy. It comes down to protection and having weight-based specific appropriate doses of epinephrine readily available that can mean the difference between a life and death in those critical first moments of anaphylaxis. So if you're not familiar, epinephrine is the first line of defense for anaphylaxis. So any delay of administrating epinephrine significantly increases the risk of a severe outcome. So by empowering and training the educators and the staff to recognize and respond to allergic reaction, regardless whether the child has a known allergen diagnosis, this legislation will closely close the life-threatening gap in care. And this bill aligns with the very mission we have carried forward in my son's name when it comes to education, preparedness, and access to ensure that the quote, "we didn't know" is no longer an excuse, and that every child, diagnosed or not, has a chance of survival. And I look that you guys support H74 to take this critical step forward in protecting children in your state. It's one of the things that we have been doing within the mission of our organization, and we're still doing it today. We have 3 bills currently in the process in Pennsylvania, Missouri. We're amending a law in New York City, New York State right now, and we have 5 more bills in the pipeline to add those guarded protection for children in the space.
Can you tell us, sorry, can I go?
Go ahead. Yeah.
No, question. Can you tell us the 6 states that have already passed this law
Yeah.
or something similar?
So, yeah, New York was the very first state to pass. It was actually the first to have a mandated legislation in such a robust, like, ironclad bill. It was the first in the nation and first in New York. Then Illinois was the second. We have Virginia, Maryland, New York, Illinois, Virginia, Maryland, California, and Arkansas. And we have also a city ordinance in Kansas City. And we just passed a city ordinance in New York City that mandates every single school in New York City to have two designated epinephrine and also to be trained. That was just a mandate that was passed in New York City in this past December. And then we're currently strengthening the state legislation in New York, which closes the gap in epinephrine access in childcare setting. And we have identified funding, which actually helps move our bills forward because of that.
And when you say you've identified funding, what does that mean?
So we've been utilizing what they call the Child Care Federal Department block grant. So there's a block grant that child care centers or the departments that regulates these child care centers can get access by submitting a funding request to get access to training and also epinephrine. So every state that we have worked in has taken advantage of that. New York has already been doing that for the past since 2019, and they've allocated so much funding to get epinephrine to be in these classrooms, to make sure training is accessible. New York State, the Office of Children and Family Services, has also developed a training which is on a federal platform that all child care centers across the country can actually get access to it. So we know we're not reinventing the wheel, we're just closing the gaps in every state. And I know this law is not in my son's namesake, but it's one of those critical pieces of legislation that I would love to see move forward.
Any other questions?
I just have a comment. I just want to thank you for pursuing this. I'm a mom. One of my children has pretty severe allergies and prevented our ability to access childcare for him. And so these kinds of rules can seem like a once in a great while emergency, but would have helped my family a lot and helped us be more economically stable if we had legislation like this in Vermont sooner. So I hope we can make that happen for other Vermonters. So I appreciate your work.
Yeah, no, thank you. It's like we saw that there was a gap needed. We actually put together a whole entire toolkit that addressed every single state in this country. And we see the gaps that are missing. And what we do, we go in there and we try to help close those gaps. Not with whether it's our law, whether it's a legislator's law, we provide our services. We don't charge anyone because we want to make sure that we can protect these children, especially the most vulnerable.
Thank you so much for, sharing your story and, presenting this. Throughout the time of some of the other states that have been able to implement the Elijah's Law, what was some of the feedback that you received from other legislations or some other challenges that may have been presented in getting this passed? More or less, was there any pushback from other sides or feedback that was like, we have some concerns?
With legislations like this, there's always concerns when it comes especially to childcare centers, because you have K through 12 and childcare do not have the same type of programs. K through 12 public schools have access to nursing. Childcare centers do not. Those are the biggest difference. So with public schools have the access to a nurse who can possibly be there and administer epinephrine, childcare centers do not. Usually it's someone who is MAT trained to administer epinephrine, or there is a training with the educators or the director in the event of an incident that they can administer epinephrine. We got a lot of pushbacks from, unions, from childcare and everything, but it's all about explaining and how this can actually save a life. Within New York State, already 11 lives has been saved through Elijah's Law, and even 2 adults that were saved because in childcare they had access to the epinephrine that was designated. So when you go back to one of the, I think whoever was speaking last, I forgot her name, is Lawland. She mentioned about using another child's epinephrine in the event of emergency. That's kind of not something someone should do. It can be illegal, impose legal actions on that because you're using a medication that's not prescribed for that person. So that leaves harm to the childcare center. So such legislation like that, we've only got pushback from the unions, but having those conversations over and over again, and even a bill that's a good bill that could actually add those layers of protection, is very, I think it's so crucial because it means the difference again between life and death. We've gotten a lot of that through every state, but we've been successful. We've been running this organization for 8 years, and within the 8 years, we're looking at already 8 pieces of legislation being passed. So that shows that there is a momentum that they see this as a good public health policy bill. Because if you look at it, food allergies is on the rise. We're talking about 1 in 13 kids with food allergic reactions in the classroom. That's 2 to every kid in the classroom. So, and there's 5.6 million children with food allergies. And that's just a number that was a statistical data from years ago. That doesn't reflect the data that's going to be coming out in the next couple of years. So those numbers are alarming, and more food allergies are on the rise. So it's like being on the front line within your state will put you in the front line and making sure you add those layers of protection.
Right, and just one quick follow-up. Have you had an opportunity to review the language of the bill as
Yes. I think one of the things is I think is a very straightforward bill and it actually helps. I think one thing we can look at is the weight-based dose epinephrine access. Because if you're working in childcare centers, you can be working with children between the ages of 0 and 4. We want to make sure that the right dose of epinephrine is administered to a child, especially at a certain weight. There is epinephrine that is out there that can actually help children that are below the 33 pounds weight base that actually they can administer epinephrine. And again, through that federal child care block grant, can give them access to getting this type of epinephrine, which is no cost to them because it is coming from a federal grant. It's no cost to them. And there are entities in each state that they can get access to third-party vendors that grant can pay for the supply and continue renewing it every year.
just a follow up with that in regards to like the language within the is aligned within the Vermont bill. Does that language seem to be consistent with the language from the other states that have passed the Elijah's Law? Or
Yes.
Okay.
And that's why
I was getting at.
Yeah, I just wanted to, when I was asked to speak because it aligns with what we're doing. So it only, hopefully I'm able to help amplify this bill for the legislator who's moving this forward, Harper. So, I just would love to see such a good policy just go through to protect children.
Absolutely, I agree 100%. I appreciate again you bringing this bill up on front and working with some of our legislators here. Thank you.
Yeah, no, you're welcome.
So we have more questions around the room. I'll go first.
Yeah, no problem.
Do you know in the other states that have passed the law, how are the childcare programs accessing the medication? Like who's being prescribed the medication and how are they getting it?
So when, if a bill goes through, then you have the Department of Public Health or the Department of Children and Family Services, whoever is regulating the childcare centers in your state will work on that in terms of once they get the access, then they work with a third party. There are a lot of third party vendors that these public health departments know how to get access to epinephrine. They work with them. They prescribe 2 doses of epinephrine to that childcare center, which those doses will be centered off away from the other children's epinephrine. So there's no confusion. So, and then used in the event of emergency. So it's really straightforward and simple. And these other states have done it. It just makes it easily accessible. And with the training within the bill should have a designated childcare person or even the educators to be trained in understanding how to recognize the signs and symptoms, how to administer epinephrine, and also call 911, right after administer use of epinephrine. So again, like I said, we have the blueprint for it. We're very we don't gatekeep anything. We're more than happy to give you the blueprint of what we've been doing within the training, within the how to access the epinephrine and so forth. You know, we've been very helpful with a lot of the other laws as well.
Thank you. Rep. Noyes?
Hi, thank you so much for being here today. Would you be able to send us more information on the block grant so that we can make sure that gets passed on
Yeah.
to the committee? Like just
Yeah.
specifically where we can find it so that we can be prescriptive on where some funding could come from.
Yeah, no, absolutely. You know,
Yeah.
and luckily, like this
Sorry.
grant was not
No,
one
no,
of the
no, I
grants.
just mean
Yeah,
it's
yeah.
childcare block grant.
Yeah.
I think you're referring to the overall childcare block grant that pretty much, I don't know if every state does, but pretty much
The
every
Child
state.
Development
Okay.
Yeah.
Sorry, I thought
No,
it was something
no.
specific.
Yeah,
to this.
Well, within that block grant, there are provisions that actually stipulate food allergy prevention and getting access to epinephrine, access to training, and also everything else that encompass.
So there might be
100%
additional
of that.
resources. Who knows?
So I'm more than happy to send that over to you. Like we have that right now. Pennsylvania is currently using that in the Senate talks. We have Missouri. Our bill is actually moving into the Senate. We actually have a bill right now that's ready processed in New Jersey. So again, these are people who are very familiar, and when you can identify the funding and so forth, that it becomes cost effective and doesn't put a burden on the childcare centers.
Thank you.
Rep. Bishop?
I think the prevalence of Narcan in communities has grown in part because of the low risk if it is used in a situation in which it's actually not called for. I'm wondering if there's any information you can share with us about risks associated with epinephrine and the level of training that may be needed to ensure that it's only utilized in appropriate circumstances.
Yeah, so the risk for that, if you're familiar with epinephrine is what our body produces on its own. And also the epinephrine that's being used is synthetic epinephrine, which if used wrongly, in the event of someone, misdiagnose someone and give epinephrine, the only thing will have like fast heart rate, jittery, but it's always good if you administer epinephrine is to go to the hospital immediately just for follow-up. But there is no harm into using the epinephrine in the event if a child is exhibiting symptoms of an allergic reaction. The thing is like when in doubt, don't delay, give epinephrine, because it's like, again, it could be the difference between life and death. So it's like, and always following through with the protocol or whatever the action plan that you have developed with your childcare center. And that's where the Department of Public Health, the Department of Children and Family Services, whoever is regulatory in that, will develop those action plans for these centers to actually put these things in place. Again, the training is free out there. It's easily accessible. We are founding members of many training programs that we can provide to your state that actually can give you this free access to training. So that's one of the reasons why we started this organization, because we want to make sure that nothing becomes a burden to these childcare centers.
Thank you. Any other questions? Thank you again so much for your testimony and all your work in advocating for this and sharing your story and you and your family's advocacy. It's apparent that your work is literally saving lives. So really appreciate everything you do.
Yeah, I appreciate that. Thank you.
Thank you.
Okay, thank you.
Okay, committee. I'm going to turn it back over to Madam Chair because we'll talk about next steps next.
All right. Okay, so I guess one of the things that would be helpful to know from committee members based on the brief testimony we heard this afternoon is any kind of recommendations that we would like to make to the House Education Committee. Certainly let them know that we took testimony from DCF and from Thomas this afternoon. I came in at the end of what Deputy Commissioner McLaughlin was talking about, but it sounded like she would appreciate a bit more time in terms of planning and things like that. We didn't hear from the health department, but I certainly would recommend that they do if they're going to consider this at all.
Janet mentioned that she did huddle with the health.
She did.
department. Yeah, so there was at least conversation, they give feedback.
Yeah. I mean, when I think about it, I mean, we certainly, you know, things like the Heimlich maneuver, things like, you know, the availability of Narcan now, things like, you know, AED devices, you know, in many public places. You know, all of these things, it seems to me along the same lines as
Sure.
epinephrine. Especially in a situation where you don't know that a child has an allergy yet. Or even, you know, people develop allergies as they get older even.
Often with food allergies, I'll say, is they often don't start out, it's not like the first time a child, sometimes, but the first time they have a habit, it may just be hives and things like that. And each time they're exposed, it's incredibly common that the reaction is worse. So something that may have just caused, you know, them to be slightly uncomfortable can quickly and suddenly turn into a life threatening incident.
Yeah.
Yeah, so children usually have their first exposures to some foods in childcare centers, and then that is the catalyst sometimes with a kid or a parent or an educator not knowing they have this allergy. So having like life-saving medication on hand, the undesignated stock epinephrine, will save a life.
So I think, you know, in terms of next steps, is there a particular, you know, we can draft a cover memo to the House Education Committee. Is there general support among committee members for them to further consider this bill?
Yeah,
Absolutely.
Okay, all right,
with time for the administration.
right, yeah,
I'm
I
sure,
get that.
yeah.
Yeah.
Centers are
Feels like,
supported
yeah.
and, yeah.
Right. Okay, all right, so that's what we will do. We will pass along the bill to the House Education Committee. They are going to consider it in their miscellaneous ed bill. We don't have an active avenue in our committee. Otherwise, you know, we could do that in our committee, but we don't have an active avenue right now. And we have this thing called crossover, and we have certain dates by which new bills have to be considered. And so this is technically a new bill, but if there's an avenue in another bill that this can be added to, it's you know, it's a possibility. So, and of course, we would encourage them to take testimony from Deputy Commissioner McLaughlin and the Health Department, as well as yourself, Thomas. So, okay, so I will do that on Tuesday, and we will move that along. And it still has life in Vermont. And if it
That's
doesn't
great.
pass this year, I encourage you to bring back next year. You know, I think it definitely has merit, and I think it's something that is important to do and important to address.
Yeah, absolutely. Thank you for your time.
You're welcome.
Sincerely
You're welcome.
appreciate it.
Thank you.
Great.
Thank you, guys.
Okay,
Be
committee
well.
members, be well. You too. Okay, I've already gone over the schedule for next week. We did get a request from Valley Vista, Lori. They want to come in. I thought maybe we could squeeze them in someplace on our testimony on 157. You think you can? I see. I know, Lori's. Where is that magic wand? So. I know. Okay, so we don't need to go over the agenda for next week because we've already done that. Anybody have any reports about any of our various bills downstairs that they want to share? You don't have to, I'm just, you know, they're in progress. I know, they're all in progress.
Well, I'll just report the RDAC, I don't know if I said that to the whole committee, I know I shared it with you, but the RDAC bill is, they added, and they had an amendment, they wanted to add a long COVID to one of, make sure that was
Yes.
included, which I agree with, and I think that's, I don't know if they heard about it or if it's just from a witness or whatnot, but that's where it stands. I have to look today to see if they voted it out or not.
So it is really important. for us to be tracking the Senate Health and Welfare agenda, to see when we have stuff. I really want on 9:38 in particular for, Eric and Esme to coordinate your schedules and make sure that we're there for, the stuff that.
You said Esme.
I'm sorry, I said Esme. I was looking at you though, Jubilee. I meant Jubilee.
Join us.
And Esme's got her own stuff. She's got her own stuff to do, right? So, we just, it's important for us to have a presence there. So, if you need to, be absent from here to be down there, you're still doing the committee's work. So, just, give me a heads up, that's all.
Which you said a lot of it was testimony going on Wednesday.
Wednesday morning, they're starting off with an hour of 9:38. Then they're doing 660 I think for an hour. It's basically like 3 hours of just our bills new, and then they're gonna do the 657.
When I look at 660, okay, so here's my thoughts on that. Goodness. So yesterday we had interesting testimony. It was good to hear from VLPOs. It's a new acronym for me this year. And it was interesting to see, honestly, that the department had sort of thought ahead in creating a structure because they knew there was going to be increasing resources coming in for prevention work. So I think that, and they thought about that in advance. So, I think that is all good. I think, Dan, you made some points around, prevention isn't only for youth, it's for adults as well. And I think we made that point yesterday. It seems clear that, the health department is very strong about wanting to keep the resources the way they are currently represented in the budget. One of the things that I brought up yesterday, and this is maybe something, Eric, for you to think about bringing up with the Opioid Settlement Advisory Committee, is I'm not sure that that's the right place then to bring prevention-related activities for funding proposals in the future. And this next year are going to be an opportunity for the committee to discuss the grants that have already been put out, looking at outcomes, looking at where we should go forward. There are limited resources and there's a growing pot of money in the prevention, which is great. I mean, I think it's good, but I guess they did talk about the dozens and dozens of local organizations that they put money out to. I wasn't convinced that it wasn't in, I think there were differences between the four regions, I guess I'll just say, in terms of, how would a local teen center know about accessing them? Now, some of them do because they've funded some of them. But I look at some of the things that got funded in H660 that we had wanted to be under this Substance Misuse Prevention Fund. And, I don't know if those organizations knew about the money through the VLPOs or not. Yeah.
I really like the model of the committee. I'm just thinking how that might be possible to, if the committee does move to that and no longer, or the opioids.
Yeah.
Considering those as how we could bring that to, if possible, the prevention. Just that concept of having a group of people with a lot of different experiences and expertise, figuring out what works, and what might, what's missing in a community and what's not, where it's not. So it becomes kind of like a community endeavor when that happens, when there's that wide group of people considering proposals.
Yeah, I mean, I think we could delve into a little bit more.
And we're not going to solve that.
No, but I think we could delve into a little bit more about the VLPOs, about how they operate and because they did reference, a committee making decisions
Yeah,
about what.
Needs assessment,
And-
like a community need, like not an assessment, but looking where the gaps are.
I actually like the fact that they didn't say they did their own needs assessment. I
Yeah,
like,
yeah,
they were looking,
yeah.
or at least I
just-
forget which one it was, but they were looking at all the different needs assessments that already are done.
and I didn't ask this yesterday, and we can follow up with them maybe, because I had to leave early. But I'm just wondering, is all of the prevention money goes to the VLP? Like, I'm just wondering how that breaks down. Like, because they did mention other kind of prevention endeavors that weren't there. So I'm just wondering, well, how the buckets of money within the prevention,
Yeah, well, and we can certainly delve into that more, like,
So say, like, I hear, that they touched on it briefly, like some of their like social media campaigns and.
they pay for
and-
staff out of the money, yeah.
Yeah, and I heard
All the money
the
goes
youth
to the
ones
VLP,
aren't
yeah.
very effective from my understanding and working and talking with youth.
Yeah,
So, yeah, I'm just wondering,
yeah,
how
so
much
no,
we're
not all the,
spending
not all the
on-
money goes to the
Okay.
VLPOs. They, all of each district has a prevention staff person, and that
Yeah.
money is paid out of there. I think in, Emily's, sort of overview, they showed a breakout of where the money goes, and
I don't think they had figures of the actual dollars.
I think that there was at least one slide, because I remember
Okay.
$1.2
I'll re-review.
million or something like that. Over $1 million is going to staff, I remember. But yeah, double check Emily's
Yeah.
presentation to see, but we certainly can, have them sort of delve into that more. And, like you said, the social media campaigns, those are statewide. Those are not something that's doled out to the VLPOs.
Yeah,
Um,
absolutely.
So,
That's why I was just kind of curious
yeah,
how those.
And one thing that came up was the money that goes directly to communities under the opioid settlement that doesn't come through here.
yeah, Ray asked about that.
Like, that was a good question, because there should be some outreach to communities so that there's some better coordination, like be proactive when that money shows up to say, we're here to help you, whether it's the VLPOs or the Department of Health.
There's no guidance right
There's,
now.
right,
from
and
anyone
it
for
might be in the
municipalities.
community's best interest to, hey, if they're coming to the table with, this is a good investment, this is some ideas where you can use this money. I don't know a lot about it, but be proactive.
We, want to say it was one of the first we scheduled, it was through, Zoom. In which, municipalities did hop on, and we, took the time to receive some questions and also,
At the
explain.
Settlement Advisory Committee?
Yeah, in which we shared, because there was a lot of unclarity in regards to how municipalities can utilize the percentages that they receive. So we got some of them, not to say that a lot attended, I'd have to go back and revisit the notes from it. But we have made that effort to reach out to municipalities and make ourselves available if they have any questions in regards to how they can
I mean,
utilize.
knowing that like the VLPOs kind of cover the state, like I do see them kind of being really like at the forefront of that is kind of coordinating the work and then coordinating with the different, because another thing is like some municipalities, like in our community, we have like Essex Junction, and Westford, who kind of share a school district, right? So when we're talking about prevention, especially for youth, that's, it's a school district that's kind of leading some of the work, or the work's happening within the school district. But like Westford gets very little money compared to like Essex and Essex Junction. But like, to me, like the VLPO can have a role there in coordinating those funds and say, okay, it makes sense for you all, maybe consider pulling your money together to fund this service, to come to your schools or to your libraries or.
Because they all use the same, they're all part of the same school
Right,
district.
exactly.
Right.
So I think that's something, there has been a gap of, like, who coordinates this work?
Yeah.
Well,
Who's,
the municipalities didn't even know they were getting the money, and then money just started appearing, you know?
so, I mean, they have the option of turning the money back over to OSAG to.
Yeah, who's gonna do that?
Some
they?
municipalities are doing that because they just rather for it to go, because they don't
To
have
somebody else.
any guidance. And they're like, the
Right.
state's already doing something with
And
it.
I'm sure there's lots of strings attached to it, so unless you can dig into how it can be used, you know, you have
Yeah,
no
the
idea.
Attorney
what's-
General's office has
Surprisingly,
like.
Really?
Yeah, for me, it's-
oversight
Well, there's
or-
no oversight.
For
There is
municipalities,
strings attached to
yeah.
it, but there's no, I actually have a bill down in GovOps that's not gonna survive this year, but I want like each municipality to at least post on their website how much they're getting and what they're doing with it, because there's zero accountability or oversight on what happens with that money.
So anyways, I just, if you could bring back, to the committee, just to have a discussion about that and sort of the intersection between that and the substance misuse prevention fund. And I didn't get the sense, I should double check. I didn't get the sense that they have an oversight committee, like they have an advisory board, I think, but I don't think they make the decisions. I don't think they make the decisions about, spending, like the OSAC committee does.
Mhm.
Uh,
And we're tasked, as you're aware, strictly the OSAC money, so it, like.
oh, right, yeah.
In regards to expressing anything in the pension fund.
One kind of, it's a theme I noticed in my work, and I did, it kind of was present to me, is everything is very school-based. And we have and thankfully it's a small population in Vermont, but we do have a population of youth who are not in school, who are often the most at risk.
Sure. How do we
And so
get to them?
thinking about our prevention and how we're ensuring, that's why I'm a huge fan of teen centers, is because that's often where a lot of those youth go, at least after school.
So 5 million goes to the BPLOs for FY 27. 3 million to school-based prevention services, 1.5 million to field-based prevention staff. That's in their state employees.
Yeah.
The total prevention budget is $18 million. And 9.5 of that is those three things that I just said. The rest of it is other things like, the media campaigns and all of that
Where did
kind
you
of stuff.
find that?
It's in the
Emily.
Emily, it's under Rick Hildebrandt's. Look under Rick Hildebrandt from yesterday.
I am looking, the slide show?
Yeah.
Which,
What?
maybe I landed on the wrong.
Yeah.
Yeah.
I opened it and it doesn't open it opened to like a slide further down.
Oh.
Yeah, and I just realized that. Perfect.
So, but that leaves like, okay.
The LPO, the
Yeah.
PLO.
See, I know, I told you, I know the
PLOs.
The L's in there somewhere.
Prevention Lead Organization, VPLO.
Okay, VPL.
Think of the PLO.
I know. So oversight, drug disposal, I
Yeah.
don't know what SMPC is,
Substance misuse.
prevention coalitions, but that might be it. Some of those are evidence-based education fund though. So there is, that fund that the manufacturers pay the fee.
Yeah.
Oh, yeah,
Okay, okay. Some of it's from the tobacco fund, which is a declining
Yeah.
dollar amount. And they just talk about tobacco control program. I don't really know what that means. But other community-based services. So you can get a sense at least of the source of funds, not necessarily the activities per se, but they were concentrating yesterday on the BPLO.
Yeah.
But there's other stuff happening. with
There's
that
other
money.
stuff, yeah, definitely other stuff. And I think that was, trying to present this, hierarchy, the personal, social, organizational, community and systems. And I thought it was kind of interesting. I'm sure they pay for instance, the youth behavior risk survey out of this, stuff like that, all comes out of this, I'm sure. I was trying to forget that this is one statistic that sort of boggled my mind under outcomes, 51.3 million impressions. I'm not sure what that means for 3 paid media campaigns.
Just views. If it came up, if you scroll past it on social media, that's an,
Yeah, it's counted.
you go to a website where there's an ad on the side, that's an impression.
Doesn't even mean that you looked at it though. That doesn't seem like an outcome to me. You know, that was the thing. I mean, it's
You should be able to.
You have no
You
control.
should be able to measure how many clicks they get off of that, what's the click-through rate,
right.
Yeah.
if you're more interested in.
Yeah, okay. That's not what they report, but. So, yeah, I mean, I'm more interested in, you know, what is,
It's actual engagement.
right, what's the engagement with the material, what's the engagement with the information, what are we seeing in the youth risk behavior survey? Are we seeing reductions in areas or increases in uptake in terms of accessing resources, those kinds of things? So, you know, it provided a lot of information that we hadn't seen before, so that was good. The map was helpful.
I will say on impressions, those can be valuable, they can be valuable too, because, you know, in marketing, they say you have to see something X number of times and that number changes before you act or it sinks in. So there's value to it, but it's not click-through rate's another valuable piece of data to have.
Yeah, I just thought like, you know, given the fact there's 660,000 people in Vermont, they had 51.3 million when they impressions or whatever they called it. I thought like, well, okay, well, that's an interesting. It's interesting as long as it's just interesting. I don't think it's an outcome. So you know, they obviously spent a lot of time putting together the presentation. They were very anxious to come talk to us, and I guess the outcome, I'm going to lead us back to where I started with 660, is I don't anticipate I think originally we were hoping that because they've given the same presentation downstairs, or are scheduled to, I'm not sure if they've actually done it yet. I don't think that they are going to move it, would be my guess, out of 660, out of the opioid fund. It's not a deal breaker from my perspective. But I think that the committee should just think, you know, going forward, how should the opioid settlement fund interact with substance misuse prevention funds? Not just that fund, but all the other funds. You know, they got $18 million on an annual basis going into that. That exceeds the amount of money that we have in the opioid settlement
And
fund.
that's a finite, but that's about ready to expire.
And it's reducing, right, every year, right? So
Years, yeah.
That's a pretty big
I'm just
priority item.
saying that I don't think we should be spending money on prevention when we have $18 million in this other bucket that can be spent on prevention. So, okay. Any other thoughts for this week? Any other thoughts about the weekend? Okay.